you for the opportunity to tell you how we first made the observation and description of the post-cesarean delivery niche. I have no disclosures. Did we predict the importance of the niche? Did we predict the future? This lecture is based on a paper that we published in 2001 entitled Saline Infusion Sonohysterography in Non-Pregnant Women with Previous Cesarean Delivery, the niche in the scar. In 2001, we reported on our findings while performing an SIS of a triangular filling defect noted under the bladder recess in the region between the uterine corpus and the cervix, in the typical location where a transverse cesarean section is performed, as you can appreciate here on the video. All patients had a history of at least one cesarean section. This finding was referred in our paper as a filling defect or niche in the scar. 44 patients who underwent saline infusion for a variety of GYN indications and who had at least a history of one cesarean delivery were included in this prospective observational study. The following information was collected: indication for the study, the number of previous cesarean deliveries, uterine dimension, the position of the uterus, and the presence or absence of fibroid. 75% of the patients had abnormal or unscheduled uterine bleeding. A uterine niche was defined as a triangular anechoic filling defect in the anterior wall of the uterus, as you see right here, between the corpus and the cervix immediately under the bladder recess. All these patients have a single filling defect. However, you can appreciate in this video, this patient had two filling defects. The depth of the niche was measured from a straight line that would have formed the normal cavity line without the niche. This is the line I'm talking about. Then we measure the thickness of the residual myometrium, which is, this is the area that we measure. 9% had a retroverted uterus with the apex of the niche pointing down or to the left on the sagittal sonographic image of the uterus, as you can appreciate here on this ultrasound. In our article, we speculated that the niche represents a normal tissue response to scarring and retraction due to growth of fibrous tissue. There are several known risks after cesarean delivery as far as subsequent pregnancy is concerned: pathological adherent placenta, implantation over a previous cesarean delivery scar, and uterine rupture or dehiscence. We also speculated that the deeper the niche or the thinner the overlying myometrium, the higher the risk for the previously mentioned complications in a subsequent pregnancy. This was clearly documented years later. In addition, we speculated that it would be invaluable if a diagnostic test such as SIS could be used as an aid in the prediction of some of these catastrophic obstetric complications. However, to assess the risk, prospective study of a patient with a previous cesarean delivery who is planning to undergo a new pregnancy is needed. Whether all pregnancies implanted in the area of the cesarean scar will develop into pathological adherent placenta is yet to be proven. In the same way, we speculated that it's not clear whether every case of placenta accreta, procreta, and increta is the result of a fertilized egg implanted in the scar of a previous cesarean delivery. Many patients with a previous cesarean delivery had abnormal intermenstrual uterine bleeding. The exact reason for the bleeding was not clear. However, in the article, we theorized that this could be due to the niche acting as a reservoir probably because of poor myometrial contractility around the area of the uterine scar. This is mentioned as a main feature of the recently defined cesarean scar disorder. This article was the first on cesarean scar niches, predicting risk and associations of the niche, stressing the importance of the niche as a source of pathologies in both OB and GYN. Did we predict the future? Maybe or maybe not, but I believe that we made bold assumptions that have proven to be correct 20 years later. Thank you very much for your attention. Have a good day.